Okay, right, fine. What I want you to do is to switch off your mics, please. Right, and if you have a question, please either put up your hand or then just unmute yourself and speak. Okay, right. Can you all hear me clearly? I can see Kurupu in front. Can you just nod? Can you hear me properly? Dushmanta.
Yes, sir, we can hear you.
All right, excellent. Okay, right, fine. Okay, let's start now. Now, children, this is the, I think, the 22nd video or lecture of this series. What I want all of you all to do, please, the ones who have just stepped into the Prof, right, is to go through all the lectures from the beginning to the end, right, and then try and get your notes and everything, because that covers quite a few topics, and that will be very useful for you all. That is number one. Number two, I would advise you all to follow these lectures physically, because I know how students function, and I'm, although you leave it for to hear it later on, it never happens, right? So it's better to physically join and listen and take your notes. Then at least these will be covered, because I remember I asked the group, then they said they have seen 3, 4, 2, 1, some none at all, the present group. So it just sometimes does not happen. So therefore, it's advisable that if you listen to all this physically, so that at least that part is covered. Okay, right. Now, the today's lecture, remember I did a lecture recently about lower urinary tract symptoms, right? And I hope you all have listened to that. And that covers the definitions and the understanding of what, how we elaborate and how we talk about symptoms, right? So that is what happened in the last session. Also, I spoke about, as far as I remember, about the investigations as to how we can investigate these problems to arrive at a diagnosis as to what it is, right? Isn't it? Dushmanta, did you watch that? Yeah.
Yes, sir.
Don't worry,
Yes.
I'm not going to ask you any question. I just asked, right? So now, so from there onwards, we are going to move on to two main topics actually. The first topic I'm going to speak to you about is in gynecology, and today we are going to cover stress incontinence. All right. The next day, that is next week, I will cover urge incontinence and urgency, and the other types of incontinence that we will meet, because those are rarer. So today's topic is a short one, and then we will concentrate on what you all need to know at the MBBS level about stress incontinence. Okay, right. Now, if you take incontinence, what does that mean? The definition means that it is the involuntary. The woman does not want to do that. It's involuntary passage of urine. Okay, that is incontinence, right? And it can be different types of incontinence, right? There can be urgency incontinence, there can be stress incontinence, there can be continuous incontinence, there can be mixed incontinence. So those definitions I have discussed with you in the last session. So today we are going to concentrate only on stress incontinence. Is that clear? Right? Okay, so now let's look at the definition of stress incontinence. Definition of stress incontinence means, right, is that there is an involuntary leakage of urine when there is an incident which increases the intra-abdominal pressure, which may be a cough, which may be sneezing, which may be laughing out aloud, which may be doing some exercise, which may be sexual intercourse, right? So anything that increases intra-abdominal pressure, and if it causes a leakage of urine, right, that is called stress urinary incontinence. Is that clear, children? That is the definition. So the questions you need to ask is that if the woman comes in saying that she is leaking urine, right, and then you need to ask whether it is associated with a certain episodes which increase intra-abdominal pressure. Okay, so that is the definition of urinary stress urinary incontinence. There's another definition. It is called urodynamic stress incontinence. What does that mean? That means, remember I spoke about urodynamic studies last time. That means during the urodynamic studies, when the graph shows that there's an increase in intra-abdominal pressure, if the woman leaks at that point, right, without an increase in detrusor pressure, remember, there are certain catheters are put inside, and then the detrusor pressure or the pressure that builds up in the bladder muscle is measured by subtracting the intravesical pressure from the intra-abdominal pressure. Remember that, right? And we get the understanding or the definition of, or we get a measurement for detrusor pressure. So if the woman leaks during the test, right, at the time where the detrusor pressure does not increase, which means there's no bladder activity, while the intra-abdominal pressure increases, then it is termed as urodynamic stress incontinence, right? So it's that definition means it comes out from a urodynamic studies, okay? Just stress incontinence means it's a clinical understanding as to, we get that from the history. So those are, they might not match exactly, because a clinician who makes a diagnosis from the clinical symptoms alone may be about 65% correct. So it's not always correct, right? So therefore, the normal understanding is, right, there is a possibility, even if you make a diagnosis of stress urinary incontinence clinically, there is always a possibility it might not be 100% correct. So therefore, it is wiser or maybe better legally as well as clinically, right, to treat stress incontinence after doing urodynamic studies. But unfortunately, in Sri Lanka, we do not have the facility to do urodynamic studies for everyone, right? And also, there are a lot of controversies coming in as to whether the urodynamic studies reflect the actual situation of the woman as well. So the urodynamic studies also may not be entirely correct, right? However, it does give us a legal stand in way, because treatment of stress incontinence is surgical. It's not the medication which you can solve. There are, of course, there are certain medication which you can miss, which you will discuss, but mostly the treatment is surgical. And therefore, when a woman undergoes a surgical procedure, we need to have a very good evidence, understanding, and reasons for us to propose a surgical procedure at that point. So therefore, if urodynamic studies are performed and they do indicate stress urinary incontinence, then of course there is a base in which we can propose surgical management for this patient. Is that clear, children? Right? Do I make myself clear, or am I confusing you all? Right? Yes, Veerasurya, is everything clear? SD Veerasurya? Yeah?
Yes, sir. Yes.
Right. So let's move on from there. All right. So what I wanted you to understand is the two definitions. One is clinically we call it stress urinary incontinence, and then of course through urodynamic studies also we arrive at a diagnosis which is called urodynamic stress incontinence. Okay. Right. Now urodynamic or stress incontinence, urodynamic stress or stress incontinence, is the commonest type of incontinence women have. Of all the types of incontinence, maybe 50% of women will have urodynamic stress incontinence or stress incontinence, right? Maybe 37% of them will have mixed incontinence, which means they have urgency incontinence as well as stress incontinence together. They have both, right? Which so basically 86% of the women will have stress incontinence one way or the other, while only 11-12% of women will have urgency incontinence. So basically the larger group are the women who have stress incontinence. Is that clear? Right? Right. It is thought that in the lifetime, right, quite a lot of women may experience stress incontinence. And it is thought that about 1 in 10 women in their lifetime will experience stress incontinence at some point in their life. Okay, so it's quite a common problem. Okay, right. Now, what you have to understand is that of all the incontinence types of incontinence, stress incontinence is has about 50% of the women will have stress incontinence, right? While as I told you, urge incontinence, mixed incontinence will be about another 34-35%, right? Right. Now, if you look at this, right now, what and how does this happen? What are the predisposing factors to develop stress incontinence, right? There are mainly 3, which you need to remember, right? What are the things that causes or might cause stress? 3 things. Number 1, anything that increases intra-abdominal pressure chronically, right? So pregnancy might be one of them. It increases the intra-abdominal pressure for a certain time, right? Then masses, pelvic masses might increase. If there's a large fibroid or something that can increase intra-abdominal pressure, then that can predispose to having stress incontinence level, right? Then malignancies, right? Ascites, right? So all these which can increase intra-abdominal pressure, a chronic cough, all that can cause an increase in intra-abdominal. So that is the first large group of factors which we call predisposing factors, right? The second group that causes or may predispose to stress incontinence are the ones that causes damage to the pelvic floor. And what are these? These are surgery, right? On the pelvic floor, maybe radical surgery or anything. And also, childbirth. So even childbirth, different types of instrumentation can cause damage to the pelvic floor. Okay, trauma of any sort and surgery of any sort can cause damage to the pelvic floor, and that can cause or predispose to stress urinary incontinence at a later stage. And the third is what we call problems with the urethra, or we call it urethral scarring, right? If there is surgery, say any type of surgery, sometimes it may be childbirth, which may cause harm to the urethra, right? Any type of urethral damage can also cause or predispose to urinary incontinence, right? So if you are asked for predisposing factors, children, 3 main groups, right? One is anything that increases chronically intra-abdominal pressure. The second group is anything that causes harm to the pelvic floor. And the third group are the ones that cause urethral scarring or injury to the urethra itself. Is that clear? So these are the 3 predisposing factors that you need to think about. Okay? And from there onwards, let us move to the mechanisms as to how this happens, because it is through the mechanisms of stress incontinence that we need to seek solutions as to why it happens, right? So if you look at the mechanisms in the world, there are mechanisms that have been proposed traditionally. And usually the mechanisms traditionally has been proposed in 3 large groups, right? The first mechanism that has been proposed to cause stress incontinence is that there is a damage to the internal sphincter of the urethra, which is called the rhabdosphincter, right? As you remember, there's an internal sphincter. So damage to that, right, due to childbirth, due to trauma or anything, or due to the fact that as time goes on, women get older and the collagen content decreases in that, and the muscle strength decreases in the rhabdosphincter. So therefore, that sphincter cannot maintain intra-urethral pressure properly. See, if for some reason there is an increase in intra-abdominal pressure, and that pressure has an effect on the bladder, inside the bladder, the pressure increases, right? And it gets conveyed to the urine inside the bladder. And therefore, the women do not leak because the sphincter keeps it closed. The intra-urethral, that is inside the urethra, the pressure is maintained by one of the mechanisms is the rhabdosphincter or the intrinsic sphincter. So if there's intrinsic sphincter deficiency, right, or it gets weak over time, right, with age or trauma or any problem, then the urine will just come out because it cannot maintain the pressure. So there is one proposed mechanism to this. Okay. The second mechanism that has been proposed, right, is that the bladder neck, due to the deficiencies in the pelvic floor, right, the bladder neck means where the urethra falls into the bladder. Okay, that is what is called the bladder. Right? The bladder neck usually lives inside the abdomen, right? Because women have a pelvic floor, and there are 3 things that perforate the pelvic floor. One is the urethra, the second is the vagina, and third is the rectum. Clear? So the bladder neck, right, normally lives above the pelvic floor, right? And because it lives above the pelvic floor, it is inside the abdominal cavity, right? So the theory is, normally the mechanism of continence means that when there is pressure for any given reason, say increase in intra-abdominal pressure, cough, sneeze, laugh, intercourse, games, whatever, right? The pressure will have an effect on the bladder, and that will cause the bladder pressure to go up inside the bladder. However, if the bladder neck is also within the abdominal cavity, that same pressure will have an effect on the bladder neck at the same time, right? And therefore, because it squeezes the bladder neck with the same force as same amount of force that it is given to the bladder, right? They cancel each other out, and the woman does not leak, or the woman is continent. Do you understand? However, with childbirth and problems and weakness and age, right, or any surgery or any problem, right, the bladder neck tends to come down, descend below from the intra-abdominal cavity down. So that is the descent of the bladder neck. And therefore, when there is an increase in the intra-abdominal pressure, that pressure has an effect on the bladder, and inside the bladder, the pressure goes up. But it has no chance to act on the bladder neck because the bladder neck has gone down anatomically. Okay? And therefore, if there is also intrinsic sphincter deficiency at the same time, then the urine will go out or leak. You all understand? So that is the second mechanism that has been proposed. Clear? And the third mechanism that has been proposed is that the extrinsic sphincter to the urethra has problems. Now, what does the extrinsic sphincter mean? Extrinsic sphincter means there are certain muscles that are acting there, right? Which is specifically the pubococcygeus, because it inserts near the mid-urethral region, right? And also there are certain ligaments, right, which supports the urethra and keeps it firm and tight, which are the pubourethral and the pubovesical ligaments. Starting from the symphysis pubis, right? They sort of encircle the urethra, right? And the ligaments sort of hold the urethra, right? So those are the pubocervical and pubovesical ligaments. And when that is damaged, then the extrinsic sphincter mechanism of the whole urethra, which is a combination of voluntary muscle, it's a combination of, that is the pubococcygeus and the surrounding muscle, then the pubovesical ligaments and the pubourethral ligaments, right? That all that mechanism does not work very well. And therefore, they cannot increase the intra-urethral pressure when the intra-abdominal pressure increases. And therefore, she bleeds, right? So either one, two, or all three mechanisms can cause stress incontinence, right? So to summarize, the traditional way of explaining this has been what? Three things, okay? One is problems, the descent of the bladder neck below the pelvic floor, number one, from the abdominal cavity. Number two is deficiencies in the intrinsic sphincter or the rhabdosphincter, right, which is a smooth muscle, right, which is called intrinsic sphincter deficiency, ISD. And the third is deficiencies in the external sphincteric mechanism, where there are voluntary muscles like the pubococcygeus, then there is the pubourethral ligaments, pubovesical, all in one complex sort of mechanism. Deficiencies of those or damage to those also can cause less increase in the intra-urethral pressure to counteract the increase in the intra-abdominal pressure. Do you all understand? So those are the three traditional mechanisms that we normally talk about when we talk about the mechanism of or the pathophysiology of stress incontinence. After some time, then a new theory came up. It is called the integral theory, right? Proposed by Alston. Alston, right? And what that said was, yes, all these are there, correct. However, the main reason for continence or keeping the continence in women, that is when a woman laughs, sneezes, coughs, has intercourse, runs, or whatever it is, when the intra-abdominal pressure goes up, the main mechanism of preventing her leaking is around the mid-urethral region. So everything around the mid-urethral region is the main thing that causes the woman not to leak. Okay? And this mechanism that causes this mid-urethral region to be firm and nice and not allow the urine to go out, there is a complex sort of mechanism there. But basically, what happens is, the theory goes on, right? It says that when an intra-abdominal pressure increases, yes, the intrinsic sphincter also tightens up, but at the same time, because the abdominal muscles are also working, and those are also interconnected to the pelvic floor, and also interconnected to the pubourethral and the pubovesical ligaments, they suddenly push up and squeeze the mid-urethral region to the back of the pubic bone, right? And what does that happen? When somebody coughs or sneezes, at the same time, the muscles and the ligaments will crush or push the mid-urethral region onto the back of the pubic bone. And that causes and increase in the intrauterine pressure and will counteract that pressure inside the bladder, and the woman will not leak. Do you all understand? So that is called the integral theory. So it is mainly around the mid-urethral region that the problem is. And it has since been shown that due to various investigations, yeah, this may be correct. And therefore, from that onwards, several very interesting, very effective therapies were developed aiming at the mid-urethral region. Okay, so which we will talk about later. Got it? So those are the four main theories that we need to speak about when we talk about the pathophysiology of stress incontinence. Right? Clear? Any questions that you all need to ask, children? Up to now? No? Right. Okay. All right. So then let's move on to what the next step is. Now, remember, we spoke about the diagnosis earlier as to how to diagnose this. So now let's basically move on to how we treat this problem. Okay. Now, before we go there, let's also have a look at a few things which there are connections with stress incontinence, right? Number one, as age progresses in women, right, the more older the woman, the higher the chance that she can have stress incontinence. So it may be due to the fact that she has had childbirth, may not, maybe due to the fact that the collagen deficiency steps in. It may be due to that the muscle may be more damaged, right? The pelvic floor. So old age, and also it may be due to the fact that there may be estrogen deficiency in the menopausal age. So all that can cause an increase in stress incontinence. That is the factors that are associated, right? Number one. Second factor that we need to talk about is race, right? Who has more? Now, we do not have much data on Asian women, but if you compare, there's data on African American women as compared to white American women. That is the data that we have. And it says that white American, Caucasian women have more stress incontinence than African American women. And also that African American women have less prolapse as well, as opposed to Caucasian women, right? So that is also something that you know. But so we actually do not know how Asian population is affected when compared to other populations. I do not know, maybe the data is there, but I am unaware of it, right? So that is the second thing. Pregnancy. Pregnancy affects incontinence. Pregnant women have more incontinence, but usually during pregnancy, they will have stress incontinence. And then obviously due to the increase in the intra-abdominal pressure due to the uterus, right? Remember, I told you that it's a predisposing factor. However, after pregnancy, normally it wears off, but in women, about 7, 8, or 10% of women who develop stress incontinence during pregnancy might continue to have stress incontinence after she has delivered as well. Okay, not talking about 10% of all pregnant women. Okay, of the women who develop stress incontinence during pregnancy, 90% will recover. About 9-10% will continue to have stress incontinence after she has delivered also. Okay, one moment, sorry. Right. Sorry. Where were we, children? Where were we? Yes, Madhushan, KDT Madhushan. Where did I stop? Now I have forgotten.
Pregnancy and the urinary incontinence.
We are talking about predisposing sort of factors, right? Associations. So pregnancy, as I told you, right? So we have spoken about that. Right. Then vaginal birth, childbirth. The more children a woman has, the higher the chances of incontinence later on, right? Does not mean that everyone is going to have one, but in the population where, if you compare a nulliparous population, women who have not had children, to a population who has had children, the population in which they have had children has an increased chance of incontinence later on, stress incontinence. Next, if you look at vaginal birth versus cesarean section, most of the studies will say that any woman who has had a vaginal birth may have a slightly increased chance of stress incontinence than a woman who has undergone an elective cesarean section. Although this data is a bit controversial, and in some factors, in some studies, it says that after a certain time, immediately postpartum period, the chances of women who have had a vaginal delivery, the chance of incontinence increases, but after about 3 months, the incidence is the same. So it's a bit controversial, we do not know, but some studies do say that any woman who has had a vaginal delivery, and especially if there's a traumatic vaginal, like forceps, a large baby, right, induction with oxytocin, right, augmentation with oxytocin, any pelvic floor trauma, right, these women may have an increased incidence of having stress incontinence later in life, right? But then any women who have had pelvic surgery, pelvic floor surgery, right, may have an increased incidence of stress incontinence, because already, as you remember, any damage to the pelvic floor can cause problems with the external sphincters, right, and the pubococcygeus muscle, which has a bearing on the midurethral region, right? So those are the factors that are associated, which you need to remember. If you ask for associated factors, right, you will need to mention these. Okay. So those are the things which I want to talk to you about. From there onwards, let us move on to treatment. So usually what happens is, right, women sometimes do not seek treatment. Some of the women are shy. They do not come to seek treatment for this condition. And some of the women strangely think that with age that this is normal, right? So therefore, there may be a portion of women out there who do not seek treatment for this condition. However, if a woman does come out and say, okay, I have this problem, can you please help me with this? Then of course, there's a pathway in which we can go to treat this woman, right? So mainly, if you look at the principles of treatment, children, remember, a very large portion or the initial treatment must always be conservative measures, all right? Which means you need to try the conservative measures first before you go on to medical or surgical treatment. Is that clear? Right? So you try with certain things, right, to try and improve this condition. And it is thought that with proper conservative measures, sometimes 30% of the problems may get resolved, right, without proceeding to other forms of treatment, right, which is quite a high good rate, right? So what are the main conservative measures? That is non-surgical measures, right? Number one is pelvic floor exercise, right? That is pelvic floor exercise is the main, or pelvic floor physiotherapy or pelvic floor exercise is the mainstay in all the treatments, or it should be the first treatment that we need to propose to the patient. Okay, so what are the other measures? There are pelvic floor exercises, right? Then the second thing is there may be what is called biofeedback, which I will speak to you. Then there is electrical stimulation, right? Then there is usage of devices, vaginal cones, and then there is usage of intraurethral or intravaginal devices, right? These are the 5 kinds of conservative management which we can do, of which all the rest are not very practical other than the pelvic floor exercises, which we need to talk about, right? Pelvic floor exercises, the woman can do it herself, or she can get supervised pelvic floor physiotherapy, okay? Of which thing, the 2 supervised pelvic floor physiotherapy is slightly better, but it may not be very practical. And most of the women will prefer self pelvic floor exercises to having supervised pelvic floor exercises at a different location, right? What are these pelvic floor exercises which you can advise these women on? Number 1, these pelvic floor exercises are usually combined with biofeedback. What does biofeedback mean? Biofeedback means what we are trying to do is strengthening or increasing the muscle strength, increasing the muscle bulk, and increasing the external sphincteric mechanism, right, of the whole pelvic floor to increase continence or to decrease incontinence. Okay, we are basically aiming at the pelvic floor muscles, so that remember the theory that shows, okay, to crush the urethra to the posterior aspect of the pubis. And these pelvic floor muscles will increase the muscle tone and will help in that. And to use that, the woman needs to understand which muscles to contract to exercise these muscles. And that is what is meant by biofeedback, right? And the simplest way of biofeedback is for the woman herself to put a finger into the vagina or 2 fingers, and you ask her to try and contract those fingers with the muscles of her pelvis. And these are the muscles that also help in keeping the woman continent. Because if you just say, okay, do pelvic floor exercise, it's not going to happen, right? Because she will not know what muscles to contract in the pelvis. And therefore, pelvic floor muscle exercise combined with biofeedback is more effective than just asking the woman to do pelvic floor exercise, right? So when she understands by contracting the pelvic floor muscles and contracting the fingers that are there, then she knows that is biofeedback. She has got the feedback, right? Okay, these are the muscles that need to contract. And therefore, she can use that doing self exercises to increase the muscle tone. And what are the other things? Number 1, she can contract these muscles 3 or 4 times daily, even when she's doing her day-to-day work. That is number 1. 2 to 3 times a day, say 10 minutes each. Number 2, one of the ways which she can exercise the muscles is while she is urinating, she can stop the urination midstream by contracting these muscles. So she can urinate, stop, urinate, stop, urinate, stop. So that can cause the muscles to exercise, to have some exercise. So those are the few things that she can do to do pelvic floor exercises on her own. Is that clear? Biofeedback can be specialized. And of course, how? But how can I? Because then you have to implant electrodes onto the muscles, right? And then ask her to contract the muscles and then tell her exactly, okay, now depending on our electrophysiological, now you can say, okay, correct, you are using the correct muscle, right? So that is how you can give specialized biofeedback. But of course, it is not very, very practical for our patients to undergo that form of biofeedback. So, but the normal biofeedback, which I told you, is far more, or is more than good enough for them to do a proper pelvic floor exercise, right? But so remember, first is pelvic floor exercises, second is biofeedback. You can do it that in combination, right? The third is electrical stimulation. And the third thing is, of course, electronic stimulation. You can stimulate the muscles by inserting a probe that gives small electric shocks to the muscles that causes them to contract, right? You know, there are lots of fashionable gadgets. It probably does not work where the muscles, to get the fat down, you have these gadgets that work, right? You have seen them all. The same thing, it's inserted into the vagina, something like that. And a small shock is given so that the muscles of the pelvic floor contracts, and that causes it to exercise, right? Which of course is not very practical thing to do. But that is also one way of conservative management, which is called electrical stimulation. The next type for conservative measurements are cones. Now, cones are weighed cones which are placed inside the vagina without any support, external support. And the woman should try to hold it within the vagina with her pelvic floor muscles. So she has to use her pelvic floor muscles to keep these cones in place, right? These are called weight cones, which can be used for her to self-exercise at home, right? Although that is also not very practical and not very much used. But it is historically important for you to understand that there are things like that as well. The next form of conservative management is having certain devices. Sometimes you can insert certain devices into the urethra, and sometimes you can insert devices into the vagina. There are certain devices that keeps the urethra flattened or changed or shifted up, right? So there are special devices, but sometimes some women even find a tampon inside the vagina may help with the stress incontinence because it causes the urethra to go upside, right? These are intravaginal devices that causes urethral displacement or changes the position of the urethra, right? So these are the conservative forms of management, of which the most effective and the easiest and the best one probably would be pelvic floor exercises, may be combined with biofeedback, but self-biofeedback probably would be the best. Do you all understand, children? So that is what you need to know about pelvic floor exercises and for stress incontinence. Okay? Right. The next portion is medication, right? And of all the medications that have been tried, right, different medication, estrogen, the application of estrogen, none of which are very effective. The only effective medication that has been tried, but it's going out of style, it's not being used a lot, is the medication called duloxetine, which has quite a lot of evidence behind it. Now, duloxetine is a reuptake inhibitor of noradrenaline, right? Because the extrinsic sphincter, the intrinsic sphincter, raptor sphincter, constricts with the help of serotonin and noradrenaline. Okay, so what it does is it prevents the reuptake of serotonin and noradrenaline, right? So these are inhibitors of serotonin and noradrenaline reuptake inhibitors. Okay, and therefore what they do is it helps through a centrally mediated mechanism. We don't really need to know the details. It increases the increases the contractility or the tone of the intrinsic sphincter, right? And that drug in many trials have been shown to be effective and reduces the number of stress incontinence in women. Okay, so what you need to know is, if you ask for a pharmacological agent, right, you can say duloxetine. Duloxetine is available, and of course it can be used as a trial. There's a certain portion of women, while on duloxetine, they will not require surgery, and they will refuse surgery because duloxetine has helped them and their quality of life to go up, right? So therefore, it is a feasible, evidence-based, good drug to use, but it is expensive and therefore may not be very suitable for many patients also due to the financial reasons, right? So the only medication that you can talk about in stress incontinence at the moment is duloxetine, as far as I know. Okay, so that is the medical treatment out of the way. Now the largest portion of treatment, right, or is surgical for stress incontinence, because it is thought mainly that stress incontinence is an anatomical problem, right? And almost all the surgical procedure, there are many, maybe hundreds of types of them, but most of the surgical procedures are aiming at two large things, two large groups. The first group is aiming at bringing up the bladder or the bladder neck back into the intra-abdominal cavity. Okay, and this is the surgery which we call colposuspension, which was innovated or described by Birch. So that is why we call it Birch colposuspension. Now, why is it colposuspension? Colpos is the vagina. The urethra goes on top of the vaginal tissue, right? So, but we cannot pull the urethra up by stitching it because it is so thin and friable and small. You can put stitches onto the urethra, as you all understand. So what is done is stitches are put onto the sides of the urethra or the vagina on which the urethra goes. And then the vagina is pulled up and hitched onto a ligament in the pelvis that causes the whole vagina to come up, and with it the bladder neck comes back into the intra-abdominal cavity. That is why it's called Birch colpo. Colpos is vagina, suspension is suspend, right? So the classic surgery is aimed at what? Pushing or pulling the bladder neck back into the intra-abdominal cavity. And it is very, very effective, right? So the long-term results are extremely good. The short-term results up to about 3-4 years is close to 85 to 90% success rate, while the 5-year results are close to 70% of women remain continued. Okay, so these are very, very, very good results. Okay, now what is the how is it done? Basically, I will show you a small video. I have a 3-minute clip, I think, where I use, so I'll show it to you. How is it done? The retropubic space is open into. Retropubic space is the space behind the pubic bone. Okay, yeah, or it's called the cave of red sears, right? If you all can remember your anatomy, hopefully, right? When it's opened into, when you go into that space, when you go down, what you're going to see is the vagina, top of the vagina, at the flow of this space, right? On the top, on this vagina, right, which shows up as a whitish thing with the fascia on it. There's a fascia on the vagina and it shows very whitish. The urethra goes on that. You can see the urethra going on that, and it falls into the bladder. So you can see the bladder neck and the urethra going on the vagina, and the fascia is also seen. Okay. So how can we identify the bladder neck? By blowing up the catheter bulb. So then when So you can actually feel or see the catheter bulb, and you know, okay, this is where the urethra falls into the bladder. Now, what is done is 2 stitches are placed at the near the bladder neck onto the vagina, and these are permanent stitches. So on both sides of the urethra, 2 stitches are placed on both sides, and then it's pulled up and hitched onto the iliopectineal ligament. So what it does is it basically lifts up the whole vagina along the bladder neck back into the intra-abdominal cavity, and that's all. And then you just stitch up the retropubic space, you just close it up, and that is what is called the Birch-Kolper suspension, which can be done laparoscopically and can be done as an open procedure. However, laparoscopically, it needs a lot of technical expertise, right? But open surgery is also feasible and can be done. So therefore, both these surgeries are extremely effective. Results are very good. And there's another reason why women, we are switching back to the Birch-Kolper suspension. The reason being, there has been a lot of controversy about the use of tapes in the recent past in many countries, right? The use of these meshes or tapes have caused women, in some women, to have pelvic pain. And therefore, earlier there was a lot of mesh slings that were used to repair the pelvic floor. And these are especially meshes that have been used to repair the pelvic floor. And this has caused chronic pelvic pain in women. And then what the women, a lot of women got together, thousands and thousands of women got together and filed a case against a certain companies that have been producing these meshes, saying this they cause pelvic pain. And this is called class action. A lot of people are getting together and filing a case. And what happened was, the court granted their wish and started and gave them started to give them compensation. So when that happened, this is not small amount of money, millions and millions and millions and millions of dollars, right, and pounds. So all the people, a lot of women came forward saying these measures, including the measures or surgeries that were done for incontinence, right, not for prolapse only, caused them pain. And then surgeons had to, or consultants or surgeons had to start to take the measures out as well, which causes a lot of problems. The tapes have to come out, and then also the courts granted the women a lot of money. So that has actually put a dampener on using measures or tapes in the pelvis for women, and therefore now surgeons are trying or are coming back to the Kolper suspension, which does not involve any tapes, right? So that is why now the Birch-Kolper suspension is again gaining popularity after a period of decline due to the fact that there were treatments proposed with measures. Okay, so this is the story about the Birch-Kolper suspension, which is gaining popularity now, right? For example, at Kaluboil, now we have switched back to completely doing Birch-Kolper suspensions, and we hardly ever do tapes now. Almost all women now we do laparoscopic Birch-Kolper suspension as the primary surgery if a surgery is required for stress incontinence. Right? So that is Birch-Kolper suspension. The second group are the slings, or the slings that are used in the mid-urethral region. So these can be natural slings, right? These are called, which can be inserts. They can be from fascia or different kinds of biomaterial, which can be used. But it's cumbersome and maybe difficult, but there are a lot of people who are very specialized in that. They do it with very good results, right? Because it is using your own women's fascia, right? You take a bit of the fascia or the sheath, right? And then you use it as a sling in the mid-urethral region. So these can be used with very good results, but maybe it is not very widely used, right? So these are mid urethral slings or vaginal slings, which can be done with their own fascia or pieces of their own fascia, right? So that is the second group. The third group, which, remember I told you that there's a theory that came in with the mid-urethral region being the culprit for the problem. And therefore, the third group of surgeries was born with this theory actually. And the target was the mid-urethral region. And what was done for the mid-urethral region? Tapes were inserted, right, along or underneath the mid-urethral region, right, to give the mid-urethral support. Now, how does it work? These are all tension-free. There's no tension. It's not tied to anything. Basically, the tape was inserted in the mid-urethral region under the urethra, right? And then what happens is, because it just lies there, it slowly started to become, fibroblasts will grow into it, and it becomes like a fascia or a ligament, and sort of mimic the mid-urethral portion of the ligaments and the extrinsic sphincter. So what happens is, when a woman coughs or sneezes or intra-abdominal pressure goes up, this artificial fascia will go up and squeeze the urethra onto the back of the symphysis pubis. So that causes, or that compensated for the mid-urethral sphincteric deficiency, which was described by Ulster, right? So do you all understand the mechanism behind it? So it is thought to be acting like a hammock. You know what a hammock is? Hammock is, you tie something between two trees and you lie on it, where in the olden days, in the ships, people slept, sailors slept on the hammocks, right? So the same thing, it's like the hammock mechanism. The tape mimicked an hammock or gave support to the mid-urethral region, okay? And there are basically three kinds of tapes. One is called the transvaginal tape, which is a tape that is put through the mid-urethral region, and it goes in the between the, on the sides of the urethra, it goes up to the retropubic space and comes out on the abdomen. And then it is inserted by special two spikes which are used. So the tape is introduced like that, right? And then the tape is cut off from above. And so it just lies there in the retropubic space and under the mid-urethral region. And that later, when the connective tissue sort of goes into it, it sort of mimics a fascia in the mid-urethral region, okay? So that is number one. However, this TVT, transvaginal tape, or tension-free vaginal tape, there is a slight problem of sometimes there may be a bladder injury, because when the tape is put in, when the spikes are used to go through the retropubic space, that can perforate the bladder. So therefore, what was required was, you do a insert one tape, you do a cystoscopy, insert the other tape, and you do a cystoscopy, and then you have to do continuous cystoscopy, because there is a possibility of bladder injury. And therefore, later on, another type was introduced, which is called a transobturator tape, right? Now, the transobturator tape, what it basically does is, it goes under the mid-urethral region, but does not go up. It goes sideways. And then it comes out through the obturator membrane by perforating the obturator membrane, okay, of the obturator canal. It does not go near the vessels. It just perforates the obturator membrane. So what happens is the tape goes under the urethra, does not go up, it goes this way, all right? And therefore, the bladder injuries became minimal. So there are special ways in which to insert it. So if you are interested, you can just look at some videos which shows how the tape goes. So there one is tension-free vaginal tape, and the other is transobturator tapes. So those are the two types. And the third type, which now these two are highly effective. Okay, we have been doing that. It's a polypropylene mesh, short polypropylene, about 40 centimeters in length. It's these are highly effective, right? And then the long-term and the short-term effects are extremely good. And almost 80 to 90% of women remain continent even after 5, 6, 7, 8, or sometimes 10 years. Okay, so these are very good. But as I told you, the problems with when the tapes and the meshes came up, it affected these as well. And therefore, the surgeons may be a bit reluctant to put them in due to the fact that there may be litigation. However, in certain circumstances, because it's a minimally invasive surgery, sometimes using tapes are better. So with counseling, if the woman understands its risks, the possibility of pelvic pain, then of course, it is a quick procedure. It can be even an outpatient procedure, can be done under spinal anesthetic or even under local anesthetic, right? So it's a quick, good procedure to for women who may be having other medical problems as well, and therefore may not be able to undergo a general anesthetic for an open or a laparoscopic colposuspension, right? So, so that is one of the things that, so in short, you can have tension-free vagina, tension-free because it is not hitched to anything. It just lies there, and then later it becomes a tight sort of band, not a tight band, a free-lying fascia-like band that gives the woman continence, right? So then later on, there was a single incision measures were introduced. You put a small incision and then a short sort of tape was put in, right? But the results of these were very minimally invasive, right? Just a small short tape was introduced. It's called TVT Secure. There was some mini lift or a few things, right? But they did not catch up very well because the in comparison to the TVT and the TVTO obturator, the results were slightly less inferior. So the popularity declined with time. Okay. So these are the surgical options that are or that have been used. You do not need to know the full complete, the way it is inserted, but I want you to understand that these are the surgical procedures and you need to understand the principle and the names behind this procedure. So in short, let's look at the surgical procedures. Number one is Birch colposuspension, right? Which is aimed at pulling back the bladder neck back onto the intra-abdominal cavity, right? Or the abdominal cavity. Remember the mechanism I told you? So we re-established that mechanism. It's very effective, right? And it has remained the classic and the standard for a treatment of stress incontinence. It was very popular earlier. Then its popularity declined due to the advent of measures or the TVTO and the TVT. And then again, when the litigation and all the problems came up, the popularity of the measures declined, and then the Birch has again come to the front. Okay, so that is Birch colposuspension. Then there are various sub-urethral vaginal sling procedures which can be used. Those are called vaginal slings that I can use by using their own fascia and sometimes different other biological measures. That is okay, but it needs a bit of expertise to harvest the fascia, and it's a bit of a surgery long to this. So therefore, the popularity is, some do it, but the popularity is not very great. But the chance of mesh rejection is not there because you are using the old woman's own fascia. The third group is the tapes, which are tension-free vaginal tape, which goes through the retropubic space. The other is tension-free vaginal tape, transobturator tapes, right, which can be used. And there are mini tapes, minimal single incision mini tapes, which are used, which is not very popular, right? So those are all the rest of the surgical procedure. There are lots of described, have not been found to be like anterior colporrhaphy, different kinds of needle procedures, all these have not been found to be effective and should not really be quoted as an effective treatment, right? So these are the surgical procedures that are used for incontinence. Okay, so that completes our treatment options for incontinence. So what you have to understand in short, number one, stress incontinence, if it is pure stress incontinence, is usually an anatomical problem, as you all understand. Some of the problems may lie in the midurethral region, some of them may be due to the fact that there's a descent with the pattern. Mostly, all patients must be start on pelvic floor exercises and physiotherapy. Okay, and I have told you which kinds, but that is the first initial treatment. If that is at least 3 months should be tried with this 3 months. Okay, if that is not effective and the woman is not satisfied, then you go on to, if she doesn't want surgery, you can try medical treatment, which is duroxetine. If that does not help and she is not satisfied, and you have urodynamic evidence that saying, yes, this woman is having stress incontinence, then of course you can go with the procedures. Now, it seems that the Birch-Kolber suspension seems with the procedure of choice due to the problems with measures. However, you can also propose tension-free vaginal tapes. You can press trans-obturator tapes, right? And if a person is proficient in doing, he can do midurethral fascial slings as well, right? But however, what is in the forefront are Birch-Kolber suspension and the 2 types of tapes that are used for this, right? So these are the things. Now remember, Birch-Kolber suspension, or especially the tapes, can give 2 or 3 problems. Number one is, it's called de novo urgency, right? What happens is, when we support the midurethral region or bring it up, doing surgical procedures, the urgency or urge incontinence, right, which was not very much apparent due to the fact that she was leaking, starts to come up. So when the bladder starts to contract, once the surgery has been done on a midurethral region, it becomes extremely difficult for the woman to bear. It is called de novo, aluteng, right? Urgency or urge incontinence. That sometimes you have to cut the tape if that happens. The next big group of complications or problems may be due to, she can have problems with urinating. There may be retention, right? When we do a surgical procedure in the bladder. When there is retention, sometimes the woman may need to self-catheterize, which is called intermittent self-catheterization to pass urine. So any woman who is undergoing a Birch or needs to be counseled, saying there is a possibility of urine retention, and there's maybe a possibility of the woman having long-term intermittent self-catheterization to pass urine, right? So that has to be counseled before we start. So those are the problems that can happen. Of course, the surgical complications, you can have bladder damage, obturator tapes can cause damage to the obturator nerves or vessels, right? And those can cause buttock pain, leg pain in certain areas, different muscular problems, right? Those are the surgical complications. But the most 2 important complications that you need to know about these surgeries are those 2: de novo urgency, and the second thing is retention, right? So that is basically all which I wanted to tell you about the incontinence part. Any questions that you want to know, children? Right. I will quickly show you. I put it out, a Birch-Kolber suspension for 3 minutes, okay? Right. Can you see my screen? Can you see my screen? Called yeah. Who is it? Huh? Can you see it? Huh? Can you see or can you not see? Can you see my screen, children? No? Yes?
Yes, sir.
You can see it. All right. Okay. So this is okay. Now just check. Can you see the video moving? Just nod your necks. Yeah. Do this. Okay. Fine. Okay. So this is. Oops. I think that is the wrong one. Hold on. Right. So this is just the, I first did a hysterectomy for this. So it's a laparoscopy hysterectomy. What you can see is the opening into the vagina to take. So now this is the picture where the uterus has been removed, right? So the next part, right, is this is now the retropubic space which is being dissected. Can you see that? Towards yourself, towards this end is the bladder, and onto that far end of the screen is the, you can see the iliopectineal ligament. You can see this white sort of thing, that is the iliopectineal, and what I am doing now is that is the vagina with the fascia. Very well, right? So towards yourself is the bladder. So this is, we are looking into the retropubic space, and this whitish thing is the iliopectineal ligament to which we need to silence. So you can see now between the vagina with the fascia, a bite is taken and then it is hitched onto the iliopectineal ligament. Can you see that? And then the whole vagina is slightly lifted up with the urethra by the assistant up there. You can see he is pushing, and this is the end result. Can you see? The whole vagina has been lifted up, and we are looking right into the retropubic space. So this is what is called a Birch-Kolper suspension. Can you see how the overview is there? That is the retropubic space, and then later it is the peritoneum is sutured, and then you will see that is the end of the surgery. Got it? Right. So that is basically all. Any questions that you want to ask now, children? Is stress incontinence clear? Yeah, that is all you need to know. Okay, right? No questions, nothing? Fine. Okay then from next week we will finish urge incontinence, right? And then we will do an obstetrics. So I will do alternatively obstetrics and gynecology, but I just want to finish off the urge incontinence next week. Okay. Okay then. Right. Okay then. Right. Okay. Okay then. Good night.
Good night, sir.
Good night.
Good night.
Thank you.